Well, hello. Now, this is a repeat of the presentation that happened this lunchtime, which was a bit disturbed by people having to rush off, and unfortunately, we didn't get a Zoom link to everyone on time. So it's the same presentation that was given this lunchtime, but in recorded format, so everyone could at least have a chance of looking at it. So we're going to talk about analgesia, sedation, and delirium. So first of all, why? Why do we sedate or give our patients analgesia? So I think it's important to remember why our patients are with us in the first place. So obviously, these patients here have often had something done to them, which is frequently painful, particularly trauma patients and particularly surgical patients. So they need to be both kept comfortable and made unaware of the support that they're getting, or if not unaware, certainly kind of it made tolerable for them. Second thing, the things that we do to our patients. So being in intensive care is a pretty unpleasant experience if you're awake, and you can see sort of 4 or 5 things here which are quite uncomfortable that we've kind of put into the patient, including lines, tubes, and also anyone who's spent a prolonged period in a bed, it's quite uncomfortable. You get stiff, you get sore, potentially. We try very hard not to, but sometimes patients get pressure areas. But even just being in bed is quite an uncomfortable place to be all the time, as we've kind of evolved to be up and around and moving. So we need to kind of think carefully about making the patients comfortable and also making them unaware of what's going on. And with that in mind, we also need to kind of think about it in relation to what's going to happen next. In relation to, we need to, if we possibly can, get through the intensive care admission and then move the patient on towards rehab. So we need to be thinking about the rehab phase of the illness right from the outset, before even we get to that stage. So we need to, when we think about sedation and analgesia, we need to be thinking about what the next step's going to be and what the consequences of our sedation and analgesia are. So analgesia. So it's really important to separate giving analgesia and giving sedation. So number one thing we need to do is think, is the patient in pain? Why is the patient in pain? And manage that pain in the same way we would any other patient. This is a really good summary. It's only about 4 or 5 pages, and I'll forward it with the link to this video. Is a summary of the things that we, or the way that we can kind of assess and manage pain in critical care. So one of the things, if any of you have had the opportunity to go to follow-up clinic, one of the sort of the top things that people often kind of complain about in their intensive care experiences is pain. Another is lack of sleep. So these are not things that are kind of particularly high tech to treat, and we just need to. So the number one thing is we need to be aware of it. So pain's still an issue. We need to kind of bear in mind that the patients are critically ill by definition, and that their kind of pharmacological handling of drugs may be different, as if organ systems are failing, and we also need to kind of bear in mind the impact that one drug might have on another. So as it says here in the middle, that sedation protocols should always focus on pain first, so that when you're kind of deciding how to pharmacologically manage a patient who's receiving critical care, we need to decide how we're going to manage their pain first, and then how we're going to manage their sedation. Opioids are very commonly used drugs, but I think we need to kind of approach pain management in the same way we'd approach the pain management of anyone, and make sure we have a sort of balanced, multimodal approach to managing that pain. So treat pain first. Assessment is difficult. It's difficult enough to assess an awake patient as to how much their pain they're in, but at least the sort of the HDU type, the non-ventilated patients, at least we can ask, and it's very important to ask. And that request can be you can there's all sorts of scales you can use, from a kind of a visual analog scale to a a visual numerical scale to even just a kind of a patient reported scale from, you know, zero pain to mild, moderate, or severe pain. And so we have to think about kind of, you know, think about how we're going to manage the pain. So first off, the WHO pain ladder. So we all know it. Start with kind of non-opioid analgesics. We frequently try to avoid non-steroidals. I wouldn't ever say that we never give non-steroidals, but we have to think very carefully before we do give non-steroidals on critical care, particularly related to gastric ulcer prophylaxis and to renal function. But in some reasons for pain, particularly musculoskeletal pain, non-steroidals may be useful, but we just have to be very careful when we're using them. Paracetamol, very good, and in IV preparation, also very effective. And then we kind of go up the ladder, as you were, to like a weak oral opiate, and then a strong opiate, plus or minus IV. Now, we also have to kind of bear in mind that the oral route may not be reliable. So we have to kind of both think about how we're going to give the pain medication, and also whether that route is going to be reliable. It's also crucial to use multimodal analgesia. We talk about a little bit in a minute, and also consider local anaesthetic. Certainly, when assessing the pain, we need to kind of think, or a kind of a useful kind of way of thinking about how to manage pain is we can manage acute pain in 4 places, and that's transduction. So that's to say where the kind of the tissue damage, the nociception, is turned into a pain, a nerve signal. Transmission, and that is how the pain gets transmitted to the sort of central nervous system. Modulation, that is usually happens in the spinal cord, and pain can be increased or decreased from the sort of the higher centers. And then perception. So perception of pain is obviously when it reaches the sort of central cortex and the higher centers. So we can treat pain at any of those sites. And when we talk about the different sorts of analgesics we use, this is the benefit of the balanced multimodal approach. And obviously we need to kind of titrate pain up and down. If we make an intervention and it turns out that intervention isn't satisfactory, then we need to kind of take the next step up. But equally, if we've made an intervention and the pain is entirely controlled, we may be able to kind of step back a little bit. So these are some common drugs that we use to treat pain. Ketamine is probably more frequently used in critical care to help manage severe bronchospasm, but certainly it's a useful kind of pain medication. And this is one of the agents that affects the modulation of pain. So, well, modulation and perception. So it creates what's described as a dissociative analgesia, and that's to say that people still know they're in pain, but they kind of feel less bothered about it, and it can be very effective. But it does come with some very significant side effects, not least some hallucinations and some quite unpleasant emergence phenomena sometimes. So nowadays we certainly use kind of higher doses of ketamine a lot less, but it is used quite significantly, quite frequently as an adjunct, and a small dose of ketamine, so 20 milligrams or kind of 0.2, 0.3 per kilo, one dose of that will give an opiate sparing effect for up to 48 hours. So it can be quite a useful drug. So the alpha-2 adrenergic agonists, so that's mostly clonidine, but also dexmedetomidine, have a sort of sympatholytic effect as well as an analgesic effect, and as well as a sedative effect. So clonidine is frequently used as an additional sedative rather than just an analgesic agent. And similarly, dexmedetomidine in some parts of the country and the world is being used as an anaesthetic agent as well, because it has some unusual or it can produce a very sort of stable and calm and yet rousable patient. So the gabapentinoids, we don't use them a lot at the moment, but certainly the acute pain physicians do. Often used for sort of neuropathic type pain. But I think some people feel that the gabapentinoids are the next fentanyl. They're really can be quite useful for some patients, but can induce certainly a psychological dependence, and are not infrequently drugs of abuse in the community. And again, amitriptyline useful for neuropathic pain, and actually frequently used as an aid to sleep, as it particularly for neuropathic pain, it's given to people at night to assist getting to sleep. And some unusual things. Magnesium is works on these spinal cord NMDA receptors, and 40 milligrams per kilogram for a 70 kilogram person, that's 2.8 grams. So we often give 3 grams, and that would, or 12 millimoles. That's really to replace electrolytes, but do bear in mind that may be given as an analgesic agent as well. So in summary, remember to think about pain, and think about pain separate from sedation. Now, the pain that people may be experiencing could be due to what's happened to them that's brought them to the unit, whether they've had surgery or trauma, or it may be because of what we're doing to them in the unit with various lines and tubes, and certainly that's a major reason we give intubated patients an opiate infusion, is to allow them to tolerate the endotracheal tube, and so that kind of so we think why the patient is in pain. We do need to kind of make an assessment of the pain. Certainly with the patients who can communicate with us, that's easier, and patients who are intubated or sedated, it's more difficult. And in those patients, we may have to rely on physiological parameters like heart rate or respiratory rate, or signs of distress like the output, monitoring the output of sort of heart rate and blood pressure and respiratory rate. And try to use a balanced multimodal approach. Now, lots of the kind of pharmacology you'll have access to. If you feel that someone might benefit from a regional anaesthetic technique and you're unable to do that, then do ask someone. There's a lot of experience within the ICU who can do that, and certainly that's something we would try to do. And if that means that we reduce the other, either sedative or sort of neuroleptic analgesics, then that's a very positive thing. So on to sedation. So again, I'll forward this to you. It's a useful kind of summary of sedation and the kind of some of the key aspects we need to think about. Again, from the BJA continuing CPD journal, which is published every 2 months, and I think available without a subscription if you go back more than 6 months. So why do we sedate people? Just to reduce their awareness of the environment. As we said in the meeting this afternoon, it's not a very pleasant place to be in intensive care. And what we need to do is just give them just enough sedation. Now, often it's there's not a battle, but there is a sort of sometimes a conflict of needs with the clinicians would like the patients a lot less sedated, and particularly in times when we're understaffed or very busy, the nursing staff want to keep their patients safe and unlikely to harm themselves. So it's often the case that sedation sometimes gets turned up just because the perception is that we need to keep the patient safe and not jump out of bed and pull out lines and punch people. So there is a kind of a delicate balance to strike between turning up sedation and turning down sedation, and we'll talk about that a little bit more as well. So we need just enough. In an ideal world, we would have the patients able to open their eyes and respond to their name and sort of settle back down within a few seconds. So it's important to monitor how much sedation they have, and it's important to set a target for sedation. So that's something that we should be doing every single ward round. And certainly I would encourage you to seek advice from whoever's leading the ward round to say, well, what do you want the sedation score to be at today? Because we certainly can't make any comment that patients are over or under sedated if we haven't made a clear request as to what level of sedation we want. So it's important to monitor, it's important to set a target, because like anything, too much sedation is associated with delirium, and we'll talk about delirium at the end of the talk, which is something that does carry a sort of an excess mortality. So this is how we, there are lots of ways to measure sedation, and this is how we do it in our unit. So the Richmond Agitation and Sedation Score. So I think anyone who is watching this is either 0, alert and calm, or possibly drowsy, but we won't go on for too long, so don't worry. So with, you know, a score of +4, you probably will have seen patients around during your medical careers who have a RASS score of +4, who are violent, immediate danger to staff, possibly a danger to themselves, and are very combative. Now you will also have seen patients who have a score of -5 who are unrousable. Now you would have seen them, but because they are not as immediately dangerous to you or themselves, they may have snuck under the radar. So what we aim to do is aim for a RASS score of -2. That's light sedation. So if you lean close to them, shout their name, they should open their eyes, may or may not make eye contact, and then drift back off to sleep. So that will be the ideal level of sedation. Now, there are some patients who we wouldn't want that lightly sedated, and those patients are often the ones who've had head injuries. So we have a kind of strict physiological guidance about how we want to manage particularly their blood pressure, their CO2, so we manage their monitoring, so they generally get kind of more deeply sedated. And similarly, patients who are post-cardiac arrest in the first 24 hours, they would need to be sort of deeply sedated as well. So there are a couple of exceptions to that, but in general, if we're picking one RASS score for most of the sedated patients on the unit, we'd be looking for a RASS of about -2. And so, as in anything, too much sedation, it has been shown to be not good for you. This is a key paper published in the New England Journal of Medicine. And the intervention, all they did in this paper was they got 128 patients. Half of them, they stopped their sedation every single day until they decided they needed sedation again. And the other half, they just let them be managed as per standard on whichever unit they're on. So this simple intervention that costs absolutely nothing saved about 2.5 days of mechanical ventilation. So those that were sedated regularly came off ventilators about 2 days quicker, and got people off the unit about 3.5 days faster. So you're just by stopping sedation every single day and making a thorough assessment, they managed to reduce both the length of stay and the time on a ventilator. So it's absolutely essential that if we're going to do sedation well, we should have daily sedation holds. Now, this is something that can be quite difficult to do, particularly if we had, for example, if we had 2 nursing staff for every single patient at all times. I suspect we would get much closer to the ideal level of sedation. But the fact is, we're frequently kind of pushed for staff, and the kind of the major concern is keeping patients safe. And if a patient is, you know, liable to kind of wake up at any moment and pull stuff out, then the tendency is that they might get a bit over-sedated. Now, the way that this hospital or this study did a sedation hold, which is generally applicable across the intensive care unit, was to stop all sedation and only restart it when it was deemed that the patient needed it. Now, and when it is restarted, it's restarted at half the level it was when it was stopped. And that way, patients have been shown to have less sedation, and as we've seen from this paper, have less sedation, spend less time in ventilators, and spend less time in critical care. And the exceptions to that are, like the exceptions for the RAS scoring. We wouldn't necessarily stop the sedation and with someone who has a head injury or in the early phase of post-cardiac arrest, thermoregulation, for example. But as you might imagine, sometimes there is a bit of reluctance to stop all sedation, just because we need to keep the patients safe. So there is a sort of a negotiation to be had about stopping sedation. So these are the kind of the common agents, but by far and away the most common is propofol. Now the standard dose of propofol is probably about 0.5 milligrams per kilogram per hour, which is up to 10 mils of 2% is 200 milligrams per hour. Excuse me. So that's perhaps a little bit more than that we would, that is sort of recommended, perhaps, but nonetheless, we stop it at that level because there is a kind of phenomenon called propofol infusion syndrome, which is manifest as a sort of metabolic acidosis. You can get dyslipidemia. You can get kind of widespread necrosis. So obviously not something that we want to kind of run into. But propofol has a very fast. Initially, it has a redistribution kind of wear off, and it's otherwise glucuronided in the liver and excreted in the kidneys. It can result in green urine, which is interesting to see. But it's safe and usually well tolerated. Now, there's almost always some hypotension that comes with propofol infusion, and sometimes we do need to start vasopressors just to kind of counteract the effect of the propofol. But obviously, only starting vasopressors after we've made an assessment of the filling state. So opiates, in this circumstance, we would use opiates. We use alfentanil mostly, and the circumstance we use them in is partly as a sedative agent, and partly as an analgesic agent for the partly as a analgesic agent for the discomfort of the endotracheal tube, and it also allows us to switch off the patient's own respiratory drive if we want to run them on pressure-controlled rather than pressure-supported ventilation. Benzodiazepines, you will see patients on midazolam, but in an ideal world we would not use midazolam, just because it is one group of drugs, the benzodiazepines, which are associated with increased levels of delirium. But it's not infrequent that we do run out of other options and have to give midazolam. In patients who are having seizures, midazolam is very good. Or we don't usually use lorazepam infusion. We would give that as a bolus dose. And again, patients who are withdrawing from particularly alcohol do frequently need lorazepam, and they're on the the CWAR chart, and usually it's chlordiazepam epoxide, but any of the benzodiazepines will do that. And another potential problem with the benzodiazepines is that you can get a dependence, and so the withdrawal of them actually can cause their own problems. Clonidine, again, also very useful. You can get analgesia and anxiolysis with little respiratory depression. And if we've got to the top of our kind of propofol sliding scale, that is frequently the drug that we would use next. It is, however, if it stops suddenly, you can get rebound hypertension, and sometimes it can give you kind of hypotension if you kind of increase the rate too high. So all of these things, it's just a balance of keeping your kind of patient calm, just sedated enough, but also safe enough. Right, so moving on to delirium. What is delirium? I mean, you will have all seen delirium, and you will probably have seen more delirium than you imagine. So it's an acute, reversible, organic mental syndrome with disorders of attention, that's crucial, cognitive function, and increased or decreased psychomotor activity, and a disordered sleep-wake cycle. So we'll go through that a little bit more. It has in the past been described as acute brain failure, or acute confusional state, or ICU psychosis, and it probably won't surprise you to learn that it happens in up to 80% of our ventilated patients. Now, if you do get a chance to go to the ICU clinic, just have a listen to some of the stories that people tell about their delirious episodes. In the meeting today, I was talking about Miles Negus, who was a patient who was in his 40s when he was with us a couple of years ago, and he had flu, and then I think he had a strep pneumonia on top of that, and he spent 90 days in the unit, and I think every single consultant had said to his family, look, we're not sure if he's going to survive, and prepare yourself. But ultimately he did, and he made a very good recovery, and he is behind the ICU STEPS group, which is a support group which is now national, which looks to help people get over and rehabilitate from their critical care admissions. Now, he came to talk at an ICU study day about his experience on ICU, particularly with delirium. And there were some absolutely horrible things that he experienced. Now, when we were watching Miles with the trachea, apparently just holding his wife's hand, he told us that there was one occasion where he was trying to squeeze a code to his wife to escape him from the ICU because he was pretty confident that we were all trying to kill him. And there was another episode where he was absolutely convinced he'd killed his entire family by trying to hide them under his bed when they all got crushed. And it wasn't until he came back into the unit that he understood that when you take a plastic apron off the roll, and if you pull it hard and make it rattle, his delirious brain was interpreting that as automatic gunfire, and he thought that Al Qaeda were on the unit, and they were just randomly picking rooms and opening up their weapons into that room, and he was just waiting for his turn to be shot by Al Qaeda. So this is the for about, I don't know how many days he experienced this, but it's a real thing, and it sounds absolutely miserable. So you're probably getting all my mail notifications as well. Apologise for that. So delirium is associated with some quite negative outcomes. It's associated with a prolonged hospital stay. It's associated with more in-hospital complications. It's associated with prolonged cognitive dysfunction after critical care. There's an increased incidence of dementia after discharge, and actually there's a mortality risk. If you have acute delirium on critical care, you're more likely to die than those who don't. And so preventing delirium ought to improve our outcomes and reduce hospital time of hospital admission and decrease cost of care. So it's important, as everything, to look for it and manage it. So there are three types of delirium. So hyperactive, and you will have seen these patients. They're the ones that are kind of pulling stuff out, kicking the nurses, trying to get out of bed, sweating, tachycardic. You may have not noted the hypoactive delirium patients who are not interacting. They're quiet, withdrawn, sometimes paranoid, sometimes just sitting there very frightened. And these two states can mix. You can go from one to the other in the same day. So we need to look out for it. So this is the hyperactive delirium. So continued movement. They're disorientated. They don't know where they are. They can't follow commands. Don't sound like they're listening. They're kind of not communicating effectively. They have sort of exaggerated pain and abnormal vital signs. So frequently hypertensive, tachycardic. They're often sweating. And similarly, the hypoactive delirium. They're withdrawn. They're quiet. They're often paranoid. They're the ones that are kind of looking past you to see who else is out there, and they wonder why there's someone standing in the room that is just looking at them in the corner. So these are all signs that someone's got basically an acute brain failure. So what causes delirium? I mean, essentially, everything we do to patients can cause delirium. Number one, whatever illness they come in with is not going to help. And then the drugs we give, electrolyte imbalance, pain can help. The effects of infection or inflammation, respiratory failure, if people are hypoxic, sort of inability to void, so impaction of feces or retention of urine can all kind of trigger it. And also, metabolic disorders, things like hypoglycemia, hepatic failure, renal failure, can all do it. And so that little kind of mnemonic, the only one it misses out is lack of sleep. Now, it's very important to recognise that for someone who's been sedated, for all the time they've been sedated, they haven't had proper functional restorative sleep. So they have been sedated, and that is very different from having a normal night's sleep. And we've all had nights where we just haven't slept for sort of several days, either professionally or personally, and you can kind of remember how wretched you feel. Well, if you kind of try and extend that to 30 or 40 days, and then suddenly you wake up and find yourself in an intensive care unit with any number of these things happening, you can kind of understand why people's brains work less well. So this is how we detect delirium. So the CAM ICU score should be done every shift, so 3 times a day, and it looks for the sort of 4 segments. So number 1, they have to have an acute change or a fluctuating mental state. So if that's the case, we can go to assessing for inattention. So we need to do some test which requires the patient to follow and sort of interact with us. So often say, often these words are kind of spelled out to the patient, and they have to kind of squeeze the nurse's finger whenever an A is said. So if you get a squeeze when it's not an A, or no squeeze when there is an A, that's an error. So more than 2 errors, and you go to looking at the altered level of consciousness. Now, if the RASS is anything other than 0, and they have inattention, they have delirium. If the RASS is 0, then you can kind of go on to looking at if they've got organised thinking. So 4 questions. Things like, can you use a hammer to hammer a nail? Or does a pound weigh more than 2 pounds? Are there fish in the sea? Will a stone float on water? And this just, if you ask them these 4 questions and they make more than 1 error, and they have inattention, then they have delirium. So we need to, and then the final thing is getting them to kind of follow an instruction. So if they come back as having delirium, that should be recorded on the chart, and it should be taken into account when we're managing the patients every day. So how can we prevent delirium? Now, we can stop the thing that's causing delirium. That's number 1 thing. So if it's due to a metabolic derangement, we need to do our best to correct that metabolic derangement. If it's a question of impaction of feces and draining the catheter, that may help. So other than that, we need to provide as far as possible an unambiguous environment. Day needs to be day, night needs to be night, and that's to say, at night time it needs to be quiet, the light needs to be off, the patients need to kind of be allowed to sleep. So we shouldn't have loud talking at the end of the bed, or lights on to do cares, or kind of care episodes that could have been done during the day done at night. So some of you may have noticed the patients having sleep hygiene packs. So this is the kind of the earplugs and the eye mask. This is to try and just tell them, look, it's night time. It's now, we're stopping the kind of the sensory and input, and we're letting you sleep. Managing noise is part of that. Trying to limit night sedation. Now, anyone who's read Why We Sleep, there's a part in that which kind of describes, if you're a regular user of benzodiazepines, there is a mortality risk associated with that. And it's not a high dose of benzodiazepines. It's only something like 16 or 20 a year will put you in a higher risk category group for premature death. And that's because when you take particularly a benzodiazepine, you're not getting natural functional sleep. You're being slightly sedated. So in that, we want to kind of switch our patients back to kind of normal night and normal day. Normal night requires them to have a sort of normal functional sleep. Orientation is crucial. So whenever you kind of go into the patient, reintroduce yourself, even if you've done it, 10 minutes beforehand. Clear communication, identify key staff. If we can kind of have the same staff with the patient, that's useful. Time orientation. So all our patients should have a clock in their room that says, day or night and the day and the date. Sometimes people bring in familiar objects from home, or increase communication with family. Providing awareness of outside events on TV. I mean, we've all been on the unit for a week and just forgotten which day it is. So you can imagine, how difficult that must be for the patients. Maintain competence. That's to say, give them their glasses, get their teeth in, get their hearing aid, and encourage self-care. Arrange to maximise sleep, and maximising sleep goes along with ensuring activity 3 times a day and getting, working them during the day in the hope that we can get them to sleep at night. And this is part of the reason why we try to get people out into the garden as much as possible, not least because it resets the day-night cycle with ultraviolet light, but also it's some activity. And I'm sure you've all kind of experienced, just feeling that you never leave the hospital. Now, that is, probably 3 or 4 12-hour shifts in a row. Some of these people stay in the same room for 30 days. So you can kind of see just how that might drive you to a sort of delirious state. And also things like, problems which occur while in the unit, including infection, pain, hemodynamic instability. All of these things can be managed. Now, drugs commonly used that are deliriogenic, pretty much everything that we use. So limit drugs as far as possible. So in summary, delirium is an acute organ dysfunction. 60 to 80% of our patients get it. It's not a benign condition. If you get delirious, you're more likely to die, and you're more likely to stay in hospital for longer. It's not normal. In order to kind of diagnose and manage it, we need to look for it. We need to, every day, consider what our target sedation is going to be, document that target sedation, and try and achieve that. We need to do a daily CAM ICU. We need to review the drugs, including the level of sedation. So requires a sedation score, an assessment, early ambulation, and a strict day-night regime. Oh, and I forgot to say that the drugs that are useful in treating delirium, often it's if someone is acutely delirious, haloperidol is usually the first line of treatment. So starting at as low as 0.5 milligrams up to 10 milligrams, and if 20 minutes later there's no response, doubling the dose and repeating it. So often people start with 2.5 milligrams of haloperidol, and then if they're still kind of wild and dangerous after 20 minutes, give them 5. Once the patient's under control, it's useful to give olanzapine, 10 milligrams at night, while doing all the other things. Now, if possible, we try to avoid benzodiazepines because they are one group of drugs which are positively associated with the development of delirium. So I hope that's been useful, and I will get that to you in the next day or so. Okay, bye-bye.